Tonight's program on Does Addiction Treatment Work will be presented by Dr. Carl Christensen. Dr. Christensen is a clinical associate professor at the Wayne State University School of Medicine and has a private practice in Ann Arbor. He is the medical director of the James Wardell Women's Recovery Center, the medical director at the Tolan Medical Research Clinic in the Department of Psychiatry at WSU, and the medical director for Don Farm. He is the past president of the Michigan Society of Addiction Medicine and the current medical director of the Michigan Health Professional Recovery Program. He is a member of the advisory board of Families Against Narcotics in Wayne County. Dr. Christensen has received numerous teaching awards and has been named one of the top docs in addiction medicine in Our magazine since 2006. Please join me in welcoming Dr. Carl Christensen.
Thank you. So I want to start off with just describing a little bit about what I do. I work with different types of addiction treatment, including medication and abstinence-based therapy that we'll be talking about. So I work at the methadone clinic down at Wayne State, and we have the top therapists and workers right in the front row here. I work at Don Farm as the medical director, which is an abstinence-based program, which we'll be talking about. And my wife and I have a buprenorphine and a naltrexone practice in Ann Arbor. We'll be talking about that. And I also work for the government as a expert witness for doctors that have hyperactive prescription pads, and I'm sure you've probably met a few if you're here tonight. So I like to describe myself as being fair-minded because I work with different types of therapy, and I've also been described as promiscuous, so I'll let you make the decision at the end of the talk. And I also need to warn you that this is really not a really uplifting talk. I've been giving this for a long time, and we started getting feedback at these sessions first, and this was one of the first remarks that I got, so my feelings were hurt, so I went home and I rewrote the talk and put in more stuff about treatment, and this was the response that I got. These are all documented. Jess can show it on paper. So something else I'd recommend that you check out is a blog from Jason Schwartz, who's the clinical director at Don Farm, and he has a blog called Addiction and Recovery News. And Jason is one of those folks who will take a article that gets a soundbite, on Google, and dissect it, and by the time he gets done dissecting the article, it doesn't look anything like what you started with. So check this out, and you can get this on WordPress if you just Google his name. So the first thing is we have to ask ourselves what addiction is, and it's not as easy as it sounds, because the majority of people, and the majority of people who treat people with addiction think it's physical, meaning, I've got this little Norco problem, but if I could just get over this Norco withdrawal, I'd be okay. Or I'm a weak-willed person, or I'm a bad person, or I've got an actual mental illness. And we'll look at each one of these for a couple seconds. So the first one, which is the most popular one still, is that addiction is physical, that I have tolerance and withdrawal to opioids, alcohol, sedatives, cocaine, whatever it is. And tolerance means that I have to use more to get the same effect. So if I'm taking a Xanax or two at night to deal with the stress of life, eventually I'll need 3 Xanax, 4 Xanax, and eventually I'll run out of Xanax because I'm abusing it, and then I'll go into withdrawal. And withdrawal is the opposite effect of what Xanax is supposed to cause. And this sounds like addiction, right? You need more to get the same effect, and you get the opposite effect when you stop, but it is not addiction. I can take everybody here in this room and force feed you morphine for 2 weeks and then suddenly stop. Everybody here in this room will get physically ill. You'll have opioid withdrawal. It'll last for a few days, and then it'll be gone. 85% of you will say, thank God that's over, I never want to go through that again. 15% of us, maybe a little higher, will go out and start robbing 7-Elevens to get more morphine because I've activated the disease of addiction in you, and I'll show you how that happens. So you can say that addicts don't have any willpower, and anyone who's talked to someone who's gone through hell just to get their drug one more time knows that willpower is not the issue. But these are 4 folks from history that are alleged to have problems with alcohol and drugs. The 2 on your left were alleged to be amphetamine addicts, and the two on your right were alleged to be alcoholics. And you can say whatever you want about them, but no one's ever accused these gentlemen of having a problem with willpower. And history is simply full of strong-willed alcoholics and addicts. Or you can say that addicts are bad people, they're evil. And everybody knows the guy on the right because of the cigar, that's Sigmund Freud. The guy on the left is considered to be the greatest teacher of cancer surgery of all time, and his name was William Halsted. These were both cocaine addicts, and cocaine took both of these doctors down. And if you're ever bored one day, go on YouTube and put in their names, and you'll see a PBS video that describes how cocaine ruined these doctors' careers. And everyone tried to help them because they were so useful as physicians, but nobody could, and they died cocaine addicts. So we're left with talking about a brain disease, a mental illness, and I'm going to spend a couple more minutes talking about the evidence for that. And the villain here tonight, if you look at this as this is a rat brain, this is the front, so it's the frontal cortex, this is the hindbrain, and in a rat it's mostly hindbrain and not much cortex. In a human it's the opposite. But the problem here is right near the front of the brain, called the nucleus accumbens, and the drug that is responsible is dopamine. Dopamine causes you to crave, and it also gives you a reward. So those of you who went out there and walked past those cookies and felt a magnet drawing you towards them, okay, that was dopamine telling you to come closer, okay? And when you finally broke down and took one of those cookies and you got that, when you ate the cookie, that was dopamine rewarding you. And that is supposed to be, in biologic terms, that's what keeps the race alive, because you have the same craving and reward for sex and food and sleep and everything else. And I'm going to show you how that's broken in addiction. You have to get the dopamine from somewhere, and it comes from right behind the pleasure center. It's called the ventral tegmental area, which just means the roof on the bottom, and it supplies dopamine to the front. And if you look at all these drugs here, all the drugs of abuse that we talk about, they either directly or indirectly feed into the pleasure center to raise your dopamine, making you want it, and then rewarding you for using it. Now, if that were the only problem, we'd be okay. But like I'm going to say over and over again, there's more bad news. So this is your frontal cortex. Those of you who had the strength to walk past the cookies, that was your frontal cortex telling your pleasure center to shut up. That's your impulse control. And that also keeps you alive. And when you go to the bar tonight on the way home and you only have 2 beers so you don't get arrested, that's your impulse control telling your pleasure center, we're not going to get drunk and get arrested tonight. And that part of the brain is unfortunately also badly damaged in addiction, probably even more so than the pictures I'm going to show you of the pleasure center. So this is you looking down at someone's brain, and this is the top, the frontal cortex. That's you. That's your impulse control, your executive functioning, your thought processes. And this is your pleasure centers. And remember, the brain is symmetric, so you have a left one and a right one. And that red is dopamine activity. So that is a normal, happy, healthy brain that's not craving too much and not going crazy, but not so low in dopamine that you feel terrible. Now I'm going to show you pictures from research done by Dr. Nora Volkov. She's the medical director of the National Institute of Drug Abuse, or whatever it's named this year. And she took pictures of 3 normal people, and that looks like what you just saw a minute ago. And that's red, that's all dopamine activity, like you're supposed to have. And then she took a cocaine addict, an alcoholic, and a heroin addict, and took pictures of their brains. And look at the difference. There's very, very little or no dopamine activity in place there. And one theory of addiction is called the reward deficiency syndrome. You just don't enjoy life anymore because your dopamine pathway is all messed up. So instead of watching TV and getting normal reward like somebody else was, you go out and you buy heroin, because heroin gives you a greater kick than any normal activity could. Another problem is that almost everybody with addiction stops sooner or later. You run out of money, you get arrested, you get sent to treatment, you decide to go on the wagon, but the overwhelming majority of addicts and alcoholics don't stay stopped. And why? Because you would think that once you got past that withdrawal, once you realized what you had to lose or what you'd already lost, that you would never go back. So even though the withdrawal is gone, addicts relapse. Why? More bad news, okay? Now we're looking at a brain. Again, here's your frontal cortex. And this red that you're seeing, red and orange, is the brain metabolizing or using up glucose. So this is how much activity a normal brain has. That's how you're supposed to look. Here is an active cocaine addict. Look at the difference. Okay, it looks like the active cocaine addict isn't thinking too much. And that's no surprise to anybody here who has a loved one who's a cocaine addict. You know you don't get a whole lot of high quality judgment from someone who's actively using. Okay, but more bad news. This is a study done by Dr. Mark Gold at University of Florida, and he took 3 normal people and took pictures of their brain metabolizing glucose. And this is how you are supposed to look. That yellow and red is your metabolism. That's your thinking process. And then he paid 3 cocaine addicts to stay in the hospital for 100 days, did drug screens so he knew they weren't using, and took pictures of their brains at 10 days after they stopped. Wow. It looks like they unplugged the machine, okay? So there's really no active higher functioning going on 10 days after you stopped using cocaine. And you may say to me, well, so what? That's only 10 days after you stopped. And I will say to you, well, guess what? That's more treatment than you are going to get in the state of Michigan right now. If you have a big checkbook and you go to one of the treatment centers around here, they are short-term detoxes, and they will release you when you are about 10 days or less. And then they wonder why you use on the way home, because you just went through all that. You just got over the withdrawal. Why did you relapse? You relapsed because your brain was severely damaged. And I always like to say, is there anybody here who would have a loved one who had a massive stroke? They went to rehab at U of M or St. Joe's for a week, and you stop by to see them in the hospital and say, here's the keys to the car. Would you pick up some groceries on the way home? No. You would send them to a rehab unit where they would learn to walk, talk, and live, and then bring them back home. But we don't do that with addiction because we see it as a withdrawal problem and not a long-term problem. Now here's 100 days at the bottom, and this is when you're supposed to have gotten your life back. You've got your 90-day chip. You're supposed to be sponsoring people. You're supposed to be going back to work. And look how badly damaged those brains are compared to the controls. And I don't think we mentioned it, but I'm the medical director for the Impaired Doctors Program in Michigan. If you were a cocaine addictive surgeon, this is right about when we would let you go back to doing surgery. So if anyone's having surgery next week, stop by the podium on the way out the door and I'll give you some pointers.
Oh boy.
Okay, now there's a big argument against all of this. We're not looking at a disease, we're looking at brain damage. You use drugs, you damage your brain. So all those dopamine pictures are just people with damaged brains. And if you're a little older, you remember this commercial. This is your brain on drugs. I think this is from the Reagan administration. And it showed how your brain will just be cooked by using drugs by a very short period of time. So is this a possible explanation? Are we just looking at brain damage and we're not looking at the underlying reason why someone's using drugs? And I didn't show you all the slides because I don't want to get overload here, but what they did was out in California, they took volunteers who they documented were not using drugs and did brain scans on them. And they looked at the amount of dopamine, how happy and healthy they were. And then they gave them IV methylphenidate, which is IV Ritalin. And anybody here who knows a methamphetamine addict, you know what a deadly addiction that is. It's destructive, and it's something you really sometimes can't recover from. And they injected them with the Ritalin and said, did you enjoy that or not? And then they looked at the brain scans afterwards to see if anything matched up. And it turns out that the people who enjoy being injected with Ritalin, who most of you would find to be a horrible experience, were walking around with low levels of dopamine, and they weren't even using drugs. And people who didn't enjoy the Ritalin, that's a normal response, were walking around with normal or high levels of dopamine. And this all happened before drug use. So if you are walking around with low levels of dopamine, this is one theory, you will like drugs more, and because you like drugs more, you are at higher risk for becoming addicted. And that can be due to your family history, your genetics. It can be due to trauma, especially for women. It can be emotional, sexual, or physical trauma. And family history is more, it seems to be more important for males, especially for males who have alcoholics in their family. So now that we know that it's bad news, let's look at treatment. So what are you looking for in treatment? And this is a big shortcoming when you hear someone talk about treatment, because someone will typically talk about what we want you to do and not what you want to do. And that's a big problem. So a lot of people who want to stop using are just looking for harm reduction, which means they don't want to stop using drugs. They just want to stop shooting heroin, or they want to stop, using cocaine, and they want to use Adderall instead, okay? Or they want to use prescription pills instead. So they don't want to stop the drug use. They want to lessen the way it affects their lives or the amount of danger they're in. Or you can say you want abstinence, which means either you're not using your drug of choice or you're not using any drugs at all. Or you say that you want the real vague one that everyone throws around. You want to be in recovery. We'll talk about what that actually is supposed to mean. So harm reduction means that you make it safer, but you usually don't stop using drugs. So if you live in Europe, you may be given syringes of heroin. If you live in Canada, they'll give you syringes of Dilaudid. They're talking about doing here in the US. And if you go to a methadone clinic, you'll get methadone, but a lot of methadone clinic patients continue to take things like Xanax and Norco because they have a bad back or they're nervous, okay? They don't want to stop using drugs, they just want to stop using heroin. And you want to decrease the harmful effects, and really this is society talking. If you want people to go to a needle exchange program, you're talking about what's best for society as well as what's best for the patient. Abstinence means, again, either the drug not being there, either the drug that you're addicted to, or any drugs. And again, I work in a methadone clinic, and we see people getting off opiates, getting off heroin, but they still use cocaine, and that's pretty common. So they're abstinent from heroin, but they're not abstinent from cocaine. And this can either be medications that we're going to talk about, or psychosocial treatment. We're also going to talk about that. And then here's the big one, recovery. What does recovery mean? And you got to have experts. So about 10 years ago, they got a bunch of experts together. They went to the Betty Ford Center, and they decided they were going to tell us what recovery was. So here it is. Recovery means sobriety, which is abstinence typically from all mood-altering substances. Health, which means recovering your physical and mental health from the damage of addiction. And here's a weird term, citizenship. Now, citizenship to them means giving back or re-entering society, and most of us would call that weird, foggy term spirituality, which I tell patients spirituality means believing in something bigger than yourself or taking direction from somebody outside yourself. And also, recovery implies a better quality of life, and I think people who work with different addiction treatment venues will tell you that people who are typically in an abstinence-based recovery program, usually abstinence-based, who work with either the 12 steps or with a spiritual program have a higher quality of life. And you can see articles that go both ways on that, by the way. Okay, so you will go home tonight and you will look up on the internet how everything I have just said is wrong, okay? Why? Because people look at different studies done different ways. So how are we supposed to do scientific research? We can do anecdotal research, which means, for example, when they started using a drug called thalidomide over in Europe, they saw kids who were born with missing limbs, which is a very rare thing to have, and all of a sudden it started becoming common, and they figured out it was from the thalidomide. So rare things becoming common. A drug called DES was causing cervical cancer in teenagers. Rare things are common. Or you can sit down and look at a bunch of hospital charts and say, here's the people that smoke, here's the people that don't smoke, who got cancer, who didn't, and you sit down and you do all the statistics and figure out what the risk of cancer is if you smoke or don't smoke. Or you can do an experiment, okay? You can give one state fluoride, another state doesn't get fluoride, and then you watch for years and see who gets cavities. Or you can give one person the drug and another person don't give the drug. You can make that better by randomizing it, meaning I don't choose who gets it. You just draw a number and you can actually get a computer program that tells you who gets drug A and drug B. And sometimes you can't do that because the patient's involved in the decision, and that's where a lot of these addiction studies come in. And then you can have a control group, which means you don't get the treatment, and that may be unethical if you think that all the treatments help, and we'll talk about that with a thing called Project Match. And finally, the most elegant one, the biggest one, is blinded, meaning I'm giving you a drug, but I don't know which drug you're getting, okay? And if the drugs look different, I give you both of them, and one's a dummy and one's real, okay? We'll talk about an example of that later on. So this is the ultimate study, is what we call a randomized, blinded, controlled trial, which is very rare in psychiatry. And the problem is that there are a lot of things you can't control, and you can't control that people know which medication they're getting. Or you can have something that's kind of fishy, there's something wrong with it, the way it was randomized, or in cancer studies, for example, one drug will make your hair fall out, the other drug will make you throw up, so there's no way not to know which drug you're getting. So that's where a study really isn't completely randomized and blinded. And this is where 95% of the studies that you read about come from. It's people sitting down with medical charts, interviewing patients and figuring out what causes what and what's the risk if you use this drug or use that drug. And then you get into the shadier area. 2C means there's no control group. So I give everybody here in the room vinegar, and I look to see what the incidence of alcoholism 5 years later, okay? And that's an uncontrolled study. Or you've got the hot air balloons, which is opinions of respected experts. And I can assure you I'm not one of them. But there's a thing called the Cochrane database that I'm going to show you a couple of studies from. And if you want to impress somebody, you say, well, the Cochrane database shows this. And the room will always get quiet because the Cochrane database has spoken. Okay. The Cochrane database is, I'm going to show you one big problem with it. It does not care about the finesse of the study. All it cares about is how rigorous the study was. So they will go through a bunch of studies on treating alcoholism and just throw studies out left and right because there wasn't the right controls or something. So when someone says the Cochrane database shows this high quality studies, the good studies may actually be littered all over the floor, and that's very common. Okay, so is there even any need for us to talk about this? There are a lot of people out there who tell us that addiction is a myth. It doesn't even exist, okay? And here is the Donald Trump of the addiction world. This is Stanton Peele. He's a very vocal person, and he will tell you that addiction is just a life phase, that he has figured this out, that everybody else is nuts, and oh, by the way, buy my book. And I would urge you to be careful when anybody finishes a statement off with buy my book. But if you want to, look him up, and he is one of the most vocal attackers of the addiction science world. And here's just another book Stanton Peele and another guy wrote that they know the truth about addiction and recovery, and nobody else does. And these statements are true. Most people who have a problem with alcohol or drugs will stop on their own. True. Think of your college classmates, your coworkers who were drinking too much, using too much, and when it finally came time to stop, they just stopped. Okay? True. The majority of people who stop usually do so without treatment. Now, there's a problem with this. The way they got this study done was they kept calling people on the phone and asking them if they stopped using. Okay? There's a tiny bit of problem with honesty with people who drink and use drugs. So if someone calls up and say, listen, do you still consider yourself a loser? I'm very unlikely to say yes. All right, so this is a suspect kind of study. And heroin addicts will quit. And there is they always talk about the Vietnam study where people came back from Vietnam and they all spontaneously quit and only a few had a problem. And I've talked to a few of the people who spontaneously quit and they kept on using for 20 or 30 years after coming back from Vietnam until they actually quit. So again, these studies are not as great as they claim they are. So this is, again, another book, Cult or Cure. You can guess which they consider it. And again, this has been, they've attacked the addiction treatment in AA very, very vocally. So let me give you a different take on things. I used to take care of cancer patients, and I'm going to make 3 statements, and then I want you to determine if the 4th statement fits. So ovarian cancer, even though it is very dangerous, is rare. Only about 2 out of 100 women will get it. So it's not common. So what's the big deal? And women get ovarian tumors, but most of those tumors are not cancer. Most of them never turn into cancer. And the only way for us to find out is to take them out, and these patients have surgery and then find out they never had cancer. Okay? So this sounds like a setup. Ovarian cancer is rare. For most people who think they have cancer, it's a false alarm. And people go through a lot of treatment and surgery to find out they don't have cancer. So my conclusion is, even though you can't cure it a lot of the times, ovarian cancer is a scam by the government and it really is not a problem. Okay? If I were to say this, you would say, this guy's an idiot, he needs to have his medical license torn up. But when people say it about addiction treatment, they say, yeah, that's right. These same facts apply to addiction treatment. It's rare. Most people recover on their own, but the people who really have it really need a lot of help. Okay, so how do you treat addiction? So one way is cold turkey, either voluntary abstinence, going on the wagon, or forced abstinence like incarceration. And those may work for a short time, and if you can't get your drug of choice in jail or prison, it will work while you're in prison, but everyone knows what happens when you get out. Or you can use what we call psychotherapy or psychosocial treatments, which is counseling, mutual groups like AA, NA, or Smart Recovery, or what we call motivational enhancement, which is trying to convince somebody to move along and get ready to stop doing what they're doing. Or you can use medication. We're going to look at all of these briefly. And also there's different levels of treatment. So you can have, for example, you can have outpatient treatment at Dawn Farm where you go once a week. You can have intensive outpatient where you go 3 to 5 times a week. You can have residential treatment at Dawn Farm where you stay from 30 to 90 days. And which one you pick or which one is picked for you depends on how bad off you are. You can have a long-term transitional housing or what we call a therapeutic community and a halfway house, or you can have treatment inside a physician's office, especially for medications like buprenorphine or naltrexone. So the level of treatment can be different, or you can talk about medical treatment, and it can be in a methadone clinic or it can be in a doctor's office. So let's start off by talking about alcohol. So alcohol treatment can be, for example, mutual help groups, Alcoholics Anonymous. It can be what's called self-management and recovery training, which is known as Smart Recovery, which is based primarily on a science called relapse prevention, recognizing your triggers, avoiding your triggers. And they have meetings here in Ann Arbor. The AA Club in Ann Arbor, the Alano Club, donated time, and they actually meet in the Alano Club in Ann Arbor. You can have what's called cognitive behavioral therapy, which works to find out the underlying reason why you're drinking. So they don't care so much that you're drinking, but they want to know why you're drinking, and they want to change that belief. Or you can have motivational enhancement therapy, and I'm proud to say that I'm one of the few people who took a motivational enhancement course and was pretty much thrown out of the course. I mean, they told me, don't come back, because you got to have a certain level of patience, I guess, and if you've worked with me, you know I don't have it. And there's also a lot of programs out there who are based on hatred of AA. And I'd urge you to stay away from them, not because AA is necessarily right, but these programs have nothing to offer except they hate AA. And they don't go any further than that. So if you look up programs like Rational Recovery, secular organization for sobriety, and you investigate them, you'll never see anything except AA doesn't work, but they never really go past that. And again, at the end, we'll say, buy my book or buy our book. And then we have medications we'll come to. Now, AA is very controversial. If you're bored, Google Alcoholics Anonymous, and probably 95% of what you're going to see is people who hate AA. And it gets kind of depressing after a while. And one of the most amusing people on the internet, no one knows who this really is someone called Addiction Myth. And he has been trashing AA for years, and this guy, whoever it is, goes to AA meetings out in California and then comes home and writes about them. He has moved on from AA to Israel. He considers Israel to be the devil now, when AA used to be the devil, and that might tell you something. But he says, something about AA seems creepy and manipulative. AA is a haven for liars, criminals, and sociopaths. AA is a school for scoundrels. So this is not an AA fan, I think it's pretty safe to say. But you will see this kind of writing all over and saying that it's, they try and brainwash you and it's a cult and they'll drag you off to church and that kind of thing. So the other most recent thing, and I still get phone calls about this, is an article by Gabriel Glazer, who is a self-styled expert on addiction, and she wrote an article in The Atlantic about the irrationality of Alcoholics Anonymous. And her main complaint about AA was that it was old. I'm not sure how valid that is, but when you read the article, she brings it up all the time. It's old. And she went to Europe and she investigated something called the Sinclair method, and I'm going to talk about it a couple minutes down the road. But she decided that the Sinclair method worked better, so nobody should go to AA, nobody should go to treatment, and everyone should do the Sinclair method. And then she talked about how she used the Sinclair method to cut back on her own level of drinking, and when you read the details, she may actually have a drinking problem. We don't know. So how about the Cochrane database? Here's what the Cochrane database says. No experimental studies unequivocally demonstrate the effectiveness of AA, or this is 12-step facilitation, which means you go to a counselor and they get ready to explain how AA works to you, which is kind of like catechism, I guess, or counseling when you're getting married. And this is done, this was written back in 2006. And why did they say this? They said this because they didn't care about the results of the studies that I'm going to show you. All they cared about was they wanted to make it a level 1 study, and if it wasn't a level 1 study, they just don't care. They throw everything else out. And that's what we're stuck with. So you need to realize when someone says, no one has ever shown that AA works, that's not true, but has it met the level necessary for the Cochrane database? The answer is probably not. Okay, and the biggest study ever done for alcoholism is called Project Match, and what they wanted to do was match up a certain personality with a certain treatment, and that part failed. But they compared AA, cognitive behavioral therapy, and motivational enhancement therapy as outpatients after you got treatment for AA. And there was no control group because it wasn't felt to be ethical. And people have come out and said that Project Match is invalid because there is no control group. And if you have a high level of statistical training, like maybe high school, you know that that is not true. Okay, so that's not a valid argument. And what they found was that patients who were angry did better with motivational enhancement therapy. And anybody who's been to an AA meeting has seen people sitting in the back kind of steaming and stewing and sitting there grumbling. Those are the people who should be in motivational enhancement therapy. Otherwise, AA was as good or better than the other training groups, and they just published a study in 2013 looking at the same people 10 years later, and AA still did better. Okay, but again, since there's no control group, it wasn't randomized, they actually tried to match the best treatment for you. It's not acknowledged by the Cochrane database. Now, anybody who has an interest, you can find this doctor's articles all over the internet, Leanne Cascudis, and it's in your handout. Dr. Cascudis is an avowed atheist, but she believes that AA, which is not a religious program anyway, is the most effective treatment for alcoholism. And let me just show you a couple of graphs that she uses to explain this. These are people who went to AA. These are people who didn't. And this is 12 months, that's 18 months. And this is how many were abstinent. So people who went to AA had about a 45 to 50% abstinence. People who didn't had about half that. And you can attack the study by saying it wasn't randomized. You didn't force them to go to AA or prohibit them from going to AA. And that's true. But this, over and over again, is what you're going to see, that people who went to AA do better. Here are people who went to no meetings for 3 months, less than 20 minutes over meetings over 3 months, less than 50, and more than 50. So these are people who are going to a couple of meetings or 3 or 4 meetings a week. And look at the percent abstinent. 60% compared to 20%. So people who don't go to AA meetings, and this was measured over a 3-month period, have a much less chance of being free from relapse than people who go. Again, you can attack this because you can say, well, this doesn't mean anything. These were the people who were ready to quit drinking, so they just went to AA because the cult told them to go to AA. Okay. And here are people who never went to meetings, went to less than 1 a week, or went to meetings weekly or more. Same thing. Look at the difference in abstinence if you went to meetings at least once a week or more. And this is a confusing one, but what it says is if you look at no treatment, outpatient, and AA, and you combine them all together, the people who went to AA did better. And this is over and over and over again. So these studies tend to outweigh the fact that they're not randomized. They're never going to be randomized. If I tell her she can go to AA and she can't go to AA, they're simply not going to do it. Okay? And it'd be disruptive to AA, and we wouldn't put up with it anyway. So, all right, let's move on to medications for alcoholism. So one of these is antabuse. If you remember back to high school days when you dissected that frog, and they had that stuff in the pan that was pink, and it burned your hands and it burned your eyes, what antabuse does is turn alcohol into that inside your body. So it turns it into something very similar to formaldehyde, acetaldehyde, and you get horribly sick. And if you've ever seen anybody drink on antabuse, their face turns red, their eyes bug out, they start vomiting, their pulse shoots up, and bad things can happen. And the idea is that if you had that experience once, you'll never drink again. Doesn't work. Now, this is where it gets kind of strange. This is a drug called naltrexone. We're going to talk about this a couple times. Naltrexone is a drug that blocks the effect of opiates on your brain, but it works for alcohol. Now, why? Because when you drink, two things happen. You stagger around, and that's actually alcohol affecting the back of your brain, and you get high, you enjoy getting drunk, and that's alcohol working on your opioid pathway, the same as you would for morphine or heroin. That's how you enjoy alcohol. If you block that part of your brain, you'll still stagger around, you'll still get arrested, but you won't enjoy it. So the idea is if you drink on naltrexone, you'll still get drunk, but you won't enjoy it, and eventually you'll stop. Now, the problem is that this originally was a pill. And if you have a loved one who's an alcoholic or you've worked with alcoholics, you know that they're sneaky people. So they tend to do things like microwave their pills, destroy the naltrexone. They paint them with nail polish. And even though you're watching them take the pill's covered with nail polish, so it goes right through you and comes out. So pills by themselves are really not an effective way to prevent someone from drinking. This just shows the effect of giving it as a shot, a 4-week shot called Vivitrol. And here are the people who stayed clean on the high dose, the low dose, and finally the placebo. And you can see there's a difference. So if you take a big shot of naltrexone, which is called Vivitrol, your chance of staying clean from alcohol goes way up. Now this is actually an aside, but I want you to remember this for whenever you read about a miracle drug. The majority of effect that we see when we do a drug study is called the placebo effect. So these are the number of days of heavy drinking that alcoholics do. And here is like 28 out of 30 days of heavy drinking. before they started the study. And here's what happened when they were just given a dummy medication. Look at the drop. There's a huge drop just by thinking you're getting treated. And also they get counseling, and they may be going to AA, and they may be getting out of the house, so that helps, but they're not getting any medication. And then here's the low dose and the high dose, and that's a tiny difference compared to this huge drop you see with the placebo effect. So be careful when you read about the miracle antidepressant. If you look at the study, number one, it was probably only tested for a couple weeks, and number two, the majority effect was just because you thought you were getting the drug. There's a drug called Campril, acamprosate, that we don't use very much. I think I have one patient on it right now. No one knows how it works, which is always kind of worrisome. And it is supposed to block craving and prevent you from drinking as much. And it's been shown to help a little bit, but not a whole lot. And here is another bad news. This is called the COMBINE trial. And they took counseling, dummy medication, the naltrexone pill, and Campril, and they mixed them all together. And they figured that one combination would be a lot better, and they were going to see a lot of results, and here's what happened. Take a pill. That's all that counts. People who were on either naltrexone or the dummy pill with counseling had the best results. Okay, there wasn't a real invigorating outcome. And all the other combinations they expected to see, none of them came true. Okay, the next thing is the Sinclair method, and you may have heard of this. Dr. Sinclair passed, but the article by Gabriel Glazer endorsed it, and given her expertise, everybody thought it was a good idea. And Dr. Sinclair had a different take on using naltrexone. What he wanted you to do was not take it every day, because the idea is if you take it every day, you block your own opioids in your brain, and you don't enjoy life, and you feel crummy, and you just say, forget it, and you go back to drinking. But if you only take the naltrexone right before you're going to drink, it's going to go to your brain, it's going to make you not enjoy drinking, but the rest of the time, you're not going to be affected. And he claimed a very high success rate, and there are only 3 docs in Michigan who offer it. I'm one of them. And I've gotten good results with patients, but they don't stop drinking. Okay? So if you are in a situation where you have to stop drinking, if you got a judge with a gun to your head or a spouse with a gun to your head, and they say you must not drink, you can't do the Sinclair method. You actually have to try drinking in order for it to work. But it does have beneficial effects. It may reduce the drinking from horribly dangerous to risky or even a safe level. Baclofen is a drug that was very popular for a few years, and there was a doctor here who used to write a lot of it. He left town. But it's a medication that's used for spinal cord injuries, and it's similar to Valium. But the problem is it works on a slightly different part of your brain, and there's no real way to get you off it. So if you're taking a lot of baclofen to stop drinking, and then you want to stop taking the baclofen, if you stop, you're going to have a grand mal seizure and wind up in the hospital. So it's something that we don't use much of. It's not FDA approved for this, but there are some people who really think it's a good idea. Okay, so let's move on to opioid dependence, which really is what people are interested in the most. And there are 2 kinds of medications we use for opioid dependence. They're called agonists and antagonists. Agonists are similar to the drug that you're trying to get rid of. So for example, you use methadone or buprenorphine instead of heroin, and antagonists block the drug, and the only one we're going to talk about is naltrexone, the opioid blocker, and it comes in a pill and it comes in a shot. And I want you to ignore, people always talk about naloxone being mixed with buprenorphine. That's called Suboxone or Zubsolv, and people say it makes a big deal whether or not you have that naloxone in there. It doesn't make any difference. So just whenever you think about this medication, buprenorphine, just think about that and don't worry about this. Now this is a slide you will see all over the internet, and I want you to ignore it because it's very confusing. But it talks about full agonists partial agonists, and antagonists. And here's how I want you to think about it. Methadone gives you the most bang for your buck. It gives you the most pain relief, euphoria, and control of withdrawal, and that's like high-octane fuel. Buprenorphine is like weak, low-octane fuel, and it's called the partial agonist. And then naltrexone is similar to water. If you put water in your gas tank, the engine won't run. If you put naltrexone on your brain, you can't respond to opiates. So when you are on methadone, or you're on heroin or morphine, you're getting Sunoco 260. That is the most you can get, and you get the most effects, including respiratory depression and death, that you can have. And a lot of people die from methadone if it's taken incorrectly. If you're on buprenorphine, Suboxone or Zubsolv, you're getting this low-octane junk that we buy to save money, right? Or if you're using naltrexone, you're putting water in the gas tank to try and block the brain from responding to opioids. So first, methadone. Methadone has a horrible reputation. People say it is worse than heroin, but that has not been shown to be what we see in the scientific literature. Mortality goes down. Drug use goes down. Crime goes down. HIV and hepatitis C plummet. Patients get less chance of relapsing on drugs as long as they keep taking the methadone, and they get their jobs back, their families back, and they can be fully functional. Okay? But anybody who works in a methadone clinic will tell you that there's not always a lot of recovery in the patients that you see, and there's nonsense going on, there's drug sales, and there's stigma, and that is also all true. And only about 15 to 25% of people who attend a methadone clinic are actually successful. And the other bad thing about methadone is it creeps up on you. If you take the same dose of methadone 3 days in a row, look what happens to the level in your blood. It goes up and up and up until it peaks about 10 days after you start. And that's the reason it works so well. It lasts a long time in your body. But if you go to the methadone clinic on Monday and you say, I need more. I'm using a lot of heroin. I need more. And you've got somebody who's not real familiar with methadone, they'll give you more and more and more, and then about 10 days later, you'll be up here and you'll die from respiratory failure. And that's the most common time when people die, the first 2 weeks they go into a methadone clinic, because they may not know what to, you can just hold the questions, okay. They may not know how to administer it. This is a study from New York City in the 80s when the HIV epidemic was in full swing. We didn't have any effective treatments, and all we could do was try and decrease exposure to HIV. And this is the results from 6 combined clinics in New York City. And what this doctor found was over 5 years, IV drug use went down 70%. This is Dr. Ball's study from 1988. And that's a huge decrease. Now, I'm not saying that these people were in recovery. They didn't read a big book. They were probably still taking, pain pills and benzos and everything else, but they weren't injecting drugs. And that was really all we had to offer back then. But remember the pictures I showed you of those broken brains. These same patients decided they were cured and they needed to leave the methadone clinic and get out of there. And here's what happened. Over a 1-year period, 80% of them relapsed back onto IV drug use. So methadone is very effective. It works as long as you take it. If you stop taking it, it stops working, which really upsets some people, but you really shouldn't expect anything else. Now, you can argue about what kind of quality of life you have on methadone. It really depends on the patient themselves. In our methadone clinic, we have people who have 10, 20 years of recovery and are doing fantastic. We have people who can't seem to stop using, and I don't think it has so much with the methadone as to what else they do for their recovery program. And I'm not talking here about methadone pills. Methadone pills are very dangerous and should be avoided because methadone pills are only 3% of the prescriptions in the US, but 30% of the opioid deaths. And here's a graph showing methadone prescriptions, methadone deaths, and opioid deaths. It's an identical line. The more methadone people take, the more deaths there are. And we could probably eliminate a big problem with overdose deaths just by eliminating methadone pills, which are given for pain, rather than methadone through a clinic. Okay, drug number 2, buprenorphine. Call it Suboxone or Zubsolv. It is less potent, it's low-octane fuel. That makes it safer, but it also means that it won't control your withdrawal as well, and some people who are using hundreds of dollars of heroin may not respond to it. And it's probably somewhere between 50 and 500 times as safe as methadone. And just to spare you a lot of agony, here's just one of the studies that shows that 2 years into a buprenorphine clinic, 40% were still coming, and of those 40%, the majority were doing well, like over 90% were doing well. And that's a number I want you to remember, 40 to 60% success for drug treatment. And what does the Cochrane database say? So the Cochrane database says that methadone is better at controlling withdrawal, so it keeps people in treatment, but buprenorphine is much safer. And again, because there are some completely controlled studies, the Cochrane database likes comparing methadone and buprenorphine. I always sneak this in because I'm an OB-GYN, and actually my specialty is taking care of pregnant patients with addiction. So this is what the government says. They publish these treatment improvement protocols, and up until like 2 weeks ago, this was the Bible. Use methadone and only use buprenorphine if you can't get methadone or if the patient won't take it. End of story. And then we started seeing about 10, 15 years ago these small studies that showed that moms who were taking buprenorphine, Suboxone, Zubsolv, were doing great. The babies were doing better. So they finally launched a complete randomized, double-blinded, controlled, experimental study in pregnant patients who are opioid addicts, and they gave them either methadone or buprenorphine. And Detroit was one of the sites, and Dr. Susan Stein was the principal investigator, and I was the OB-GYN for the study. I was the midwife. And I'm not going to go through all these, but just to show you that every finding was better for the buprenorphine babies except for the bottom one. 1 out of 3 moms on buprenorphine dropped out, whereas only 1 out of 5 moms on methadone dropped out. And that's been used as an argument against using buprenorphine during pregnancy. But the reason for this is mainly is that buprenorphine makes you feel normal, and if you take enough methadone, you'll get high. And people prefer the effect of methadone. And the other thing is that we were taking patients on methadone and trying to put them on buprenorphine, and you can't do that. So, but this study really shows that the drug of choice for a pregnant mom who's addicted to opiates should be buprenorphine. Okay, drug number 3. Remember we talked about naltrexone being an opioid blocker, and you can take it in a pill or you can take it in a shot. This is talking about using the shot for opioid dependence. And this is real pictures. This is an addiction treatment center in Russia. And if you think it's bad here, what they do is they bring you in this big room, they handcuff you to a cot, and you go through withdrawal, which consists of nausea, vomiting, and diarrhea, which is why the guy in the bottom bunk looks so nervous. And they handcuff you there for 2 weeks, and then they let you loose, and you go out and you relapse. The relapse rate's 100%. And in Russia, when you run out of heroin, you turn to something called crocodile, which is codeine that's been put through solvents, kerosene, phosphorus, iodine, and it's really not good for your body. And here's a picture of a crocodile user. Okay, this is still a human being, but one side of her face is gone, and you're looking at her skull. Her eye's gone. And that's because anything that you inject the crocodile into will dissolve. So the drug company went to Russia and said, you want to try this out? And they said, oh yeah. And what they did was they took a couple hundred heroin addicts, they randomized them, double-blind, controlled, and half of them got Vivitrol, half of them got a dummy shot, and they looked to see who stayed clean. Here are the ones that got the real shot. Here are the ones that got the dummy shot, And you can see there's a difference. Not a big difference, but there's a difference. And this study actually shows that Vivitrol works better than placebo. But I want you to remember something. What was the success rate of these folks before they started the study? 0. Okay? So just by enrolling in the study, you went from hopeless to 40% were doing okay. That's either the placebo effect or drug treatment. They got counseling, housing, they got off the street, they were given someplace to go, and that is probably, to me, the most significant part of the study. But it did show that Vivitrol worked. Now, why do you have to have a handcuff on a treatment center when your withdrawal is gone in a couple days? Craving. Craving is what causes relapse. If you talk to someone who just got a year clean from alcohol and drugs, and you ask them, what were you been thinking about for the past year? They'll tell you alcohol and drugs, okay? The craving can be so overwhelming that people will give up anything in order to go back and use. And it seems like a blocker would make the craving worse, right? It's like putting you in front of a candy store and then putting bars on the windows. But what they found was, oops, the slide got pulled out. But what they found was that the people who were on the Vivitrol had less craving. And the one slide that I wanted to point out here is that addiction is not just withdrawal, it's craving, compulsion, loss of control, and use despite consequences, the 4 C's. Remember the 4 C's, and that's how you define addiction. And here's the craving score on people who got the dummy shot, and here's the craving score on people who got the real thing. So even though it doesn't make a lot of sense, the craving went down. Okay, now another problem. I've been doing this for a while. I know I look very young, but I've been doing it for a while. And I have never once not had a patient say on the day I started them, when can I get off this? And they would often say medication or they would say something else, okay? But everybody has always asked, when can I stop? I had it happen like 3 times today. You know, how long do I got to stay on this? Okay, so how effective is it to try and get off a medication once you've started it? So here is I like the pregnancy studies. Here is a study from England. Dr. Ludi believed that methadone was the work of the devil and nobody should be on methadone. So he found 101 pregnant addicts and he tried to get them to detox without using medications, and it worked for 40, which is a good number. 40% success is nothing to laugh at. And they said, this shows that you can come off opioids during pregnancy, you don't need methadone, you don't need anything special, and everything's going to be okay. But at delivery, out of the 101 patients, they found 1 negative drug screen, 1%. And that's the natural history of untreated addiction, it's relapse. Untreated addicts will relapse. Here's a study from Sweden. They took 40 active heroin addicts and they put all of them on buprenorphine and got them off the heroin. And then half of them stuck around, stayed on buprenorphine, went to counseling. Half of them got to do what all my patients want to do. They tapered off the buprenorphine, they were cured, and they went back to their lives, right? Here's what happened. Here's the people who stayed on the buprenorphine. 75% were still abstinent, and nobody died. Here's the people who tapered off. Nobody was abstinent, and 20% were dead. So just detoxing, remember we were talking about withdrawal is not addiction. Just detoxing has really no long-term benefit. Now, just to show this real quickly, because this is the most important study ever done for buprenorphine in the real world. This is a study where they took 650 opiate addicts who had back pain, okay? And you probably know somebody who won't stop taking Norco because they have back pain, okay? And they put them on buprenorphine, gave them counseling, kept them on it for a couple of weeks, and then spent about a month or so tapering them off, thinking these people are going to be okay now, they're going to be out of withdrawal and everything's going to go all right. 94% relapsed, okay? So they said, oops, let's go on to phase 2. There were still like 360 patients sticking around. They went back on buprenorphine. Now they did it for 3 months, which is longer than any of your clients, patients, loved ones want to be on that for, and then they spent another couple months tapering them off, and that should definitely work, right? It's got to work. If half of them stayed clean while they were on the buprenorphine, remember that number, 40 to 60%, but 93% relapse coming off it. So what this study tells us is a couple things. This medication works half the time, and most medications do in addiction. You can have back pain and you can still be successful. But when you tried to stop, people relapsed. And also they looked at counseling and they found that counseling was not very beneficial, and people are arguing whether that's real or not. And some people say that you should stop calling it medication-assisted treatment and just say it's medication treatment. And people do not agree on this one aspect. So for medication-assisted therapy, meaning methadone, buprenorphine, and naltrexone, it works half the time. When you stop it, it stops working. Okay, is that a big surprise for a chronic illness? No. And another bad thing is that once you stop it, you are now sensitive to the medications you used to abuse. So if I'm just coming off my methadone and I'm thinking, you know, I'm not gonna go back there, but I'm just one night. And I go out and I buy 4 packs, which is what I usually buy, and it kills me because my body is not able to tolerate it. And buprenorphine is safer than methadone. Methadone probably has a better chance of keeping somebody in treatment. Okay. Now what about no medication at all? Okay. We've already talked about alcohol, and I showed you that the use of AA is probably more effective or as effective as anything else. But what about opioids? The information is really, in most cases, not there. And it's not because it doesn't work, it's because no one studies it. There's nothing organized, because if you tell a drug company, how would you like to spend $50 million on not using a drug? They won't return your call, okay? So if you just look at things like counseling, psychotherapy, treatment groups, the outcomes are not that great for people who are opioid dependent. And there are studies from Europe looking at huge numbers of patients who have been in residential treatment, and these studies are just ignored. And they're called the NTOR study, the National Treatment Outcome Research Study, but you have to dig through the literature to find these. They're kind of way on the bottom. So are there any exceptions? And obviously, since I asked that, you know the answer is yes. And here's the exceptions. What we call safety-sensitive professions. And that includes pilots, and that's what gets everyone's attention is pilots, lawyers and judges, law enforcement, and healthcare professionals, including physicians, nurses, nurse practitioners, pharmacists. And these are the people that we expect to do a better job at taking care of us and not show up to work drunk or hungover, okay? Anybody nervous about having their 747 pilot hungover when they show up? Okay, so we expect them to be at a higher standard than we expect of ourselves in most cases. And there are programs for each one of these that monitor impaired doctors, nurses, pilots, lawyers, law enforcement, and their success rate is astronomical, okay? For medicine, they're called physician health programs, and there may be nursing programs in Michigan. They're all rolled into one, and these are called the gold standard for addiction treatment. The success rate is over 80%, closer to 90%, and it's been shown to go on for 10 years. And it works for opioid addicts as well as alcoholics. So you can take a physician, a nurse, pharmacist who's addicted to opioids, and they can successfully complete this program with an 80% chance, which is 2 to 3 times higher than anything else. And in most cases, we didn't use medications. And you get evaluated, you get sent to treatment, you have to go to either 12-step or smart recovery. You have to call in every day for 3 to 5 years and find out if you have to give a drug screen. You know that someone is always watching you every day, and that has a huge effect. And again, we don't use medication therapy in most cases. And here's one of the most important things. If something happens, and you may relapse, We find out and we intervene immediately, we take you off work, and we send you back for an evaluation, and you may get sent back to treatment. So let me give you a cynical view of what people say about why these programs work, because they work so much better than the stuff I've been showing you all night. They work because doctors have more to lose. Okay, I work with pregnant moms and postpartum moms, and in Michigan there's a law called the Binsfeld Law that says that if CPS intervenes, not only we will take your kids, we'll take all the kids you have and all the kids you're gonna have. We will take everybody from you. Is there anybody who has more to lose than that? And the answer is no. And actually it turns out that moms do as well as doctors in most cases until they deliver, and then once they know no one's watching, they tend to relapse. These programs work because doctors are smarter. I've been teaching medical school since 1990. This statement is not operative. They work because doctors can afford treatment. That may be true if you get to somebody before they've lost everything, but we have docs who are living in the Salvation Army and complete the program. They've lost everything, okay? They do have 2 or 3 lawyers, you know, and they've got a criminal record, but everything else is gone. They work because doctors get special treatment. That's true, but not in the way that people mean it when they say that. We expect more from pilots, lawyers, cops, and doctors. And we get more, and you get these results. And again, they're very successful. Now, do you have to be a 747 pilot for this to work? Here is a program from Hawaii called the Hawaii Opportunity for Probation Enforcement, the HOPE program. And some of the people, these are usually methamphetamine felons. These are pretty sick puppies. And some people are in a special program called the HOPE program, and some people are on regular probation. And here's the success rate on people on regular probation. Those numbers look familiar, 47, 46. The programs are about 40% effective when you're on regular probation. But when you use the HOPE program, which is almost identical to the doctor's program, with methamphetamine addicts in Hawaii, the success rates, these are actually reverse numbers, these are failure rates. The success rates are 80%, the same as a doctor would get or a lawyer would get. So you don't have to be a doctor or a lawyer or a nurse. You just have to be in a program where they watch you nonstop and they intervene immediately if something goes wrong. And there's a program in Washington State called Swift and Certain, which means that when something goes wrong, they don't just tell you to go back to jail and finish your term, they put you back in treatment. But if you don't get it, if you keep on relapsing, you're going to go back to jail for a while, and then they'll let you out and let you try again. And it works. Okay. How much time we got left?
About 20 minutes.
Okay, so let me just finish off very quickly, talk about Narcan. We've been talking about naltrexone all night. Naltrexone is for opioid treatment, Vivitrol, Revia. Naloxone is what is used in Narcan that is supposed to reverse an overdose. And when you hear all this stuff about people overdosing over and over again and being rescued by first responders, that's Narcan, okay? This works for weeks, this works for minutes, okay? So it doesn't do anything except bring you back from the dead. And it won't work for alcohol, sedatives, or stimulants, but if you're mixing your heroin with alcohol or sedatives, it may reverse the heroin part and bring you up high enough in your breathing so you can stay alive until EMS comes. And again, if you're mixing drugs, which a lot of people do, reversing the opioid part might save you long enough to get to the hospital. And here's the different versions. These 2 versions up here are 0.4 milligrams per dose. I've been using that since 1977, 0.4 milligrams. And it worked for decades. And then fentanyl came along in the heroin, and the 0.4 milligram dose didn't work anymore. So they now make a 4 milligram dose, 10 times stronger, and they put 2 of them in the pack. So instead of getting 0.4, you get 8. And that's because of fentanyl being in heroin, or fentanyl analogs, because it's so much stronger than a small dose of Narcan. And here's our therapy dog, Olive. We'll come back to her. So who overdoses? People who stopped using, people who went to detox, went to treatment, people who left the methadone clinic, quit using Suboxone or Vivitrol, people who are mixing alcohol, benzos, and heroin, because that works on different parts of your brain, and it's a double whammy. And here is the big nightmare right now, fentanyl. Here's a drug, I'm sorry, let's skip these. Here's a drug screen from a pregnant patient in our methadone clinic downtown. She thinks she's using heroin. She's pregnant, she's using fentanyl, okay? Now, what we used to do is we used to sit down and try and counsel them. We would warn them. We would tell them they were in risk of dying. But as soon as they heard they had fentanyl in their heroin, their eyes would light up. It's kind of like paying for a Chevy and getting a Cadillac. And you can't tell somebody, don't go back to your dealer because they're putting fentanyl in the heroin. That has the opposite effect. So what do you do when someone overdoses? Basic, make sure they're really overdosed. Before you do anything else, call 911. Now, why would you stop and call 911 before you would save somebody? Because once you start saving somebody, you're going to get all worked up and you're going to forget to call. And then the Narcan's going to wear off and you're going to think, where is that damn ambulance? And you realize you never called 911. So stop, call 911, put it on speakerphone and lay it down next to you. How many people here are certified in CPR? Okay, the problem is that even the CPR website says, don't do CPR for a drug overdose. Do rescue breathing, which basically, I'm going to give you a little more detail, but you don't want to compress their chest. That just moves blood, but the blood has no oxygen in it. You want to inflate their lungs artificially so you get oxygen in their blood. You give the Narcan, go back to the rescue breaths, 1 every 5 seconds, and then give more Narcan if you have it. So how can you make sure someone's overdosing? If they're turning blue and they're gurgling, then there's really no question about it. But sometimes they're just sleeping it off. So you can do something painful, okay? You may see that they're limp, they've got blue lips, blue fingernails, you can't shout at them, and don't trust a pulse to tell you they're not overdosed because the pulse is the last thing to go. So you can rub their breastbone, that's painful, you can mash under their nose, you can twist something, you can squeeze their trapezius muscle, that's very painful, and if you don't get a response, then you know you're in trouble. Call 911, don't forget to do that, lay the phone down and they may actually talk you through it. And for rescue breathing, you want them flat on their back, tilt their head back, and I'll show you a rescue mask which you may want to have with you if you've got a loved one who's using, but you pinch their nose and breathe into their mouth, and you want to see their chest move. If their stomach moves, you're breathing into their stomach. So if you see their stomach move, tilt their head back a little more and try again. Here is a rescue mask. It comes in this orange kit. I ordered these on Amazon for like $5, and it has a one-way valve so you can breathe in, but they can't throw up at you. And also, if they've used fentanyl or carfentanil, just you being exposed to that could be fatal. You've probably heard about the first responder who brushed some powder off his coat and wound up in the ICU. And this is how the mask is supposed to look. This is a mask my dad brought back from Africa. And when my dad passed, I inherited it. And I don't really understand why, but no matter where I put this in the house, it always winds up back in my study. So I think it moves on its own. My wife just kind of helps it move back into my study by herself. But the mask goes around the head, and the pointy end is up, and there's a valve right there. And again, here are the formulations. Here's the 4 milligram and the 0.4. And then when EMS shows up, people are going to start sticking needles into people, so watch out for the needles, because up to 95% of intravenous drug users have hepatitis C, and you don't want to get exposed. And now that somebody is being brought back from death, you have what we call a window of opportunity, which means you may be able to talk them into going into treatment. And they actually have what they call recovery angels. They have volunteers who go to the hospitals and meet with people who have just overdosed and try and get them the resources to get into treatment. And here's another, this is one of Jason Schwartz's blogs, and he talks about this, and he says that Narcan alone is not good enough. Okay, so is anybody not depressed? All right, so, okay. So this is what happened to, I think, 3 of our counselors back at our own clinic on Jefferson one year. They came out and their wheels were gone, okay? And this gets kind of depressing, and if you work in a big clinic like that, you get yelled at a lot, especially me, because I'm always giving the bad news. And you eventually ask yourself, why am I doing this? And there's a doc named Tom McClellan, who was the drug czar of the US for a brief time during the Obama administration. And what he did was he looked at addiction and other chronic illnesses. And what he found was failure rates are about 60%, success is 40%. Remember that number I kept telling you. And there's a lot of reasons for people to relapse, but people relapse. So often people will say, well, if this is going to happen, why even bother? Why even send them to treatment if they're just going to start using? So he looked at other chronic illnesses, and what he found was the success rate for diabetes, asthma, and hypertension is, guess what, 40 to 60%. These are all chronic, incurable, but treatable diseases. And if you were a diabetic and you stopped taking your insulin because you got fed up and you went into a coma and you wound up in the ICU, I would come and see you and say, you almost died. Here's your insulin prescription. Come see me next week and don't do it again. But if you were an addict and you stopped your methadone, your buprenorphine, your AA meetings, and you relapsed and wound up in the ICU, I would come see you and say, you're an addict, you're hopeless, you're fired. We've all done it. I have done it. It's because when people relapse into their addiction, they become very unpleasant, they're manipulative, and it just gets very hard to take. But it should be considered to be one of these chronic, incurable, but treatable illnesses. And this is my wife, Kathy. She's a nurse practitioner. Wave, Kathy. And this is our therapy dog, Olive. If you come to our office, you will meet Olive and you will pet Olive, or you won't be allowed to leave the waiting room. And just to show you how serious the addiction treatment business is, this is our office staff. They're all sitting down there. Okay. We have 3 dogs in the office. We've got 1 real therapy dog and 2 blind geriatric rescues. So at this point, I'd like to thank you for listening, and I'll take any questions. You had a question, ma'am, before. So the 15% numbers, the question is, when I said 15% for methadone, what did I mean? That means people who are abstinent for everything except possibly for marijuana because of the medical marijuana law in Michigan. Over half of the patients who go to a methadone clinic will stop using heroin. So the number fits in, but the other drugs like cocaine are harder to treat because we don't have a medication for it. So the question is, do children show signs of low dopamine? And the answer is, I don't know. I couldn't quote anything for you, sorry. No. I'm scared of kids, so. Yes, is Vivitrol covered under insurance? And this is one of the strange things about insurance in the US. It's covered by Medicaid, but it may not be covered by Blue Cross, right?
Yeah.
So if you're on Medicaid, you're all set. It's covered once a month. And your office visit is also covered. Everything's covered. Sir, so the question is, what role does Adderall play in this? Adderall is a prescribed legal stimulant for a diagnosable medical condition, but it is very often abused, often in college and even in high school by kids who are studying for exams. It's supposed to be prescribed for ADD, and in medical school we have something called the ADD virus that hits during exam week. So everybody takes Adderall during that week. And it's easy for somebody who has a history of, say, cocaine addiction to find a doctor to prescribe them Adderall or Ritalin and just use that to maintain their stimulant addiction. So the question is, if you're talking about using the physician's program as an example for the public, how do you control for their health care coverage? And the answer is actually that the health care coverage doesn't cover it, because it's for monitoring, it's not for treatment. So they may let you go to treatment and pay for it, but once you get out and you got to start doing drug screens and go to groups and go to a doctor, they don't pay for it. And the other problem with these programs, if you look at the programs for pregnant patients like we have downtown and the programs we have for doctors and nurses, part of it is that we have what we politely call leverage, which they frequently call having a gun to their head. You know, if you want to keep your baby, you will stop using. If you want to keep your medical license, you will stop using. And you don't have that as much with the general public because you see people walk away from their families and their jobs all the time. When it comes to alcohol, and when you're talking about risk factors for alcohol, there's an old line that says, if it's very important if you're a male with a parent who's an alcoholic, it's very important if you're a female with a history of trauma. And those two things are different, and they're gender differences in the risk for addiction. I can look at the handout with you afterwards. All right, thank you. I'll hang around for any other questions afterwards.